So I think we're going to start. Today I'm going to have each one of the panelists go through and introduce themselves, talk a little bit about their credentials, the work that they do, and share a little bit about their background with trauma and any work that they've done with trauma. So Dr. Green, do you want to start?
My name is Pam Green, and I'm a psychiatric clinical nurse specialist. And that's a national certification, which almost doesn't exist anymore. Those of us who have it from a long time ago can continue it, but now, of course, the movement is for psych mental health nurse practitioners. What we are able to do is certainly assess, diagnose, and provide therapeutic interventions. I've been a nurse always in psychiatric practice for over 40 years. I've been in multiple settings, including the Air Force to private practice and the Menninger Clinic most recently prior to coming here to teach. One of the things when related to trauma is I was in the Air Force immediately post-Vietnam. So we saw many people, and at that time the military provided essentially 100% of care for all active duty dependents and retirees. So we saw a lot of people with trauma, and we didn't even know what we were looking at. But I will certainly never forget the day when a child was visiting, had a balloon, the balloon popped, and the result was like bone chilling when you saw everybody just kind of hit the deck. And we're like, what? So we've come a long way now to the point of the national movement of trauma-informed care. That is approaching everyone that's new as though they may have experienced trauma, not necessarily have a diagnosis of PTSD, because we know that somewhere in the neighborhood of 31 to 82% of people have experienced trauma, and that may be impacting how they're coming in or choosing not to come in. And so I'll be talking about that as we go on with our case study in a few minutes.
Well, my name is Claudia Schmidt, and I'm a counselor. And my background is I've worked in mental health for many years. I've done some inpatient work. The longest experience I've had is working for the local mental health authority here in Corpus Christi, known as Behavioral Health Center in Nueces County. While I was there, I obtained my master's in clinical mental health counseling. And then following that, I entered the doctoral program here for counselor education. And so I currently work for the Nueces County Juvenile Probation Department, and I'm in private practice. So I work a lot with young people, adults who've experienced trauma. Since about 2014, I've seen more young people who have come in for maybe petty crimes is what we call them, like theft or just assaults, simple assaults. And really what we're finding is that they're involved in other things like sex trafficking, or they've been sexually assaulted by someone. There's other issues going on, and so we see a lot of that type of trauma. Anytime you're working with juvenile justice as well, you're going to see more of that. And so that's been my experience. I worked with them using trauma-focused cognitive behavioral therapy, and then also have had training in cognitive processing therapy, and I use that in my private practice. So that's a little bit about me and what I do.
Hello, my name is Stephanie Fuentes Majors. I am currently the eye care case manager here on campus, housed within the Division of Student Engagement and Success within the Office of the Associate Dean of Students. I have a bachelor's in psychology from TAMU-CC, and I have a master's in counseling from TAMU-CC. So I'm alumni. I am a first-generation Mexican-American college student. I'm a registered yoga teacher, and I'm working on my LPC intern license now. I get supervision off campus with Dr. Linda M. Shake. And so I get to do some private practice stuff within Dr. Shake's office in her private practice, but on campus, my primary role is that of the eye care case manager. So I don't know how many of y'all are familiar with the eye care program, but I am considered what's called a higher education case manager. And we're kind of split into two groups. There are clinical higher education case managers, and there are non-clinical higher education case managers. I'm considered non-clinical. because I work in the student affairs side. We do have a clinical case manager. Her name is Anna Salazar. She's over in the counseling center, and she does really good work out there. But me being non-clinical, I get referrals from all over campus. Parents, students, staff, faculty. I've worked with Dr. Green before, and so I work with students in distress. And when students come to me and they're in distress, most of the time they're dealing with a mental health challenge, about 75% of the time. They're dealing with a mental health challenge. The majority of them are undergraduate students. Majority of those undergraduate students are freshmen, and they're coming in with all sorts of different kinds of life experiences and backgrounds, and a lot of trauma sometimes. So I get to work on that end with students in terms of assessing needs, developing a plan. I don't call it a treatment plan because I'm non-clinical. I call it a success plan. And so we meet regularly to review that success plan and make sure the student's on track and getting all the support that they need. My main focus with my students is self-care and self-advocacy, and getting them connected to as much support as possible. Prior to working here at TAMU-CC, I worked with Claudia over at Behavioral Health Center in Oasis County. So she and I have known each other for quite some time. But they are, like Claudia said, our local mental health authority. So I worked with youth ages 3 to 17 there. And then I transitioned here to higher education, where I work with 17 to my oldest student has been, I think, like 75. So quite a range of ages here on campus. But yeah.
My name is Dr. Shireen Traylor. I work here in Corpus. I relocated about 5 years ago to work for the Department of Veterans Affairs here. My position there is as a clinical psychologist, and my specialty is trauma and the relationship between that and substance abuse. So I see a lot of people that we classify as dual diagnosis. In that position, we do a lot of assessment, primarily, as was already mentioned, because there's lots of people who have trauma disorders or have issues related to trauma, but not necessarily having post-traumatic stress disorder. And so one of the first steps we take is to go ahead and do an assessment to clarify exactly what symptoms are present so that we can better identify what treatment needs are appropriate. Some treatments might be more extensive than a person might need if their main issue is nightmares, for example. And so I work in that area doing individual therapy, group therapy, couples therapy, and it's been very rewarding. I've been with Veterans Affairs here for about 5 years, as I mentioned. Prior to that, my background, undergraduate, I was a biology psychology major. Getting out was my first experience with trauma. I worked as a teacher for juvenile probation, and that was an experience. And I learned a lot about people who had been traumatized, and it didn't look the way that people would expect it to. It might look like crimes or needing food and shelter because there was so much poverty, and so prison was better. And that was my first kind of eye-opening experience. And after that, I went to graduate school to get my master's and doctorate at Oklahoma State, and started working in the community. And my youngest client there, my first young trauma patient, was an assault of a 3-year-old. And so that was the youngest client that I had, and just kind of continued my work from there throughout practicum, and then graduating, and took the job here. Thank you.
We're so glad to have all of you here. And I was thinking at the beginning we could maybe talk a little bit about just some of the things that you found to be rewarding working with people with trauma and helping them learn how to cope and move through that trauma. So if y'all want to just jump in, I'd love to hear some of your experience.
For me, getting my students to graduate. I have, on average, anywhere between 5 and 10 students a semester who successfully graduate. So that's always exciting and very rewarding when I have students graduate and go off to graduate school or start their careers. So getting students to graduation is very important and very rewarding.
I would say for me, it's when they see that they can recover. So like once they realize like that they can move past, or they can, they see how resilient they are, that's just the most rewarding for me. Because they really can, but in the beginning, most times, they don't see that. They don't have that vision that you have. And so you hold that for them until they get there, so.
I think that's a great point, because there used to be such an image that if you had trauma, you never recovered. It lasted forever. You know, PTSD never went away.
You're broken.
Exactly,
Yes.
you were broken. And so for me, I would agree that piece of seeing that there can be a change, or even that awareness of, okay, I'm reacting like that, but I don't have to do that right now. And being able to help them work through that process, it takes a lot of courage and a lot of strength, and it's very difficult. And that's been motivating even when you do hear the difficult stories or what's happened over time. That part for me is very rewarding.
I think for me, it's become at this phase, the part that's rewarding is the recognition that we have to embed trauma-informed care in all healthcare settings. It isn't about the specific treatment as much as educating primary care providers on how to set up your office, for instance, and how to approach people when you don't know. And that movement was active in inpatient psych because so many people were admitted that had been in seclusion and restraints, for instance, and that was traumatizing for them, and then how to sit with them and avoid that situation. And then it sort of spread to pediatrics, and if any of you have children, you may have experienced with your own child that when they needed a shot, people came in and held them down, and I see some head nodding, and then what happens the next time they need an immunization or a shot? Not loving it.
Yeah.
And so it's sometimes on what seeming simple routine things we can change in healthcare to make much better, and then understanding that there's certainly much more serious examples than that. So now, in terms of what's rewarding, I just recently was invited to do an article for a Texas publication that will go to all Texas nurses to trauma-informed care and how to approach that mindset no matter who, because we know most people aren't diagnosed, and so it really is getting it into a broader sector. So that to me is pretty exciting.
So I know that working with individuals with trauma can also be challenging and presents sometimes unique challenges. So I was wondering if you could also share maybe some of the things that you found most challenging as you worked with clients with trauma.
Well, you're all thinking, again, I'm going to be back to not so much with the clients, but in my role, I'll step back because it's taking care of the caregivers who are providing care for those people. And it's like many of you know that my specialty area is suicide prevention. And for people who work with a lot of suicidal people or people with high levels of trauma, you can be, as providers, traumatized in a secondary way. So that notion of helping people genuinely take care of themselves so they don't get to that point of being traumatized themselves or experiencing burnout and leaving the field, those kinds of things. That's the challenge to me, is really helping next generations understand the importance of self-care.
I guess from the case management side of things, a challenge, and Claudia has done case management before, so she definitely can agree with me on this, but the lack of resources. We're pretty lucky on our campus. We have quite a bit of resources, and I want all of my students connected to as much support as possible. But when I have students graduate or go off to a different university, transfer to a different university in a different city, getting them connected to resources there can be a challenge. And even here in Corpus Christi, we've gotten a lot better since I've been in the mental health field, but we still have a lot of work to do in terms of access to resources and supports, especially for those who have been impacted by trauma.
So I guess for me, I would say that one of the challenges that I've run across is that when you're in the field working, it doesn't look like, go back to what you were talking about, it doesn't always look the way you think it's going to look when you're working with individuals who've experienced trauma, and treatment doesn't always look the way this says it's gonna live. So I can recall working with one client, and she wanted to be able to work through her trauma, but she had this fear of telling the story. So we had to come up with a very unique way of trying to do that. And I remember that was really early on in my career. And for her, it was more of a safety concern, and a very valid one. Not one of like, oh, they'll get out of jail and find me, but it was way more serious than that. It was find me, my family, like everything. So it was much bigger than that for her. And so I remember consulting, and they shared with me to have them do a fictional story. And so I never forgot that. So it was like creating this fictional story of these characters, giving them names, telling it the way you need to tell it so that she was able to work through it. She wanted to work through it. She wanted to tell it. She felt like she needed to. She just didn't know how. And so she created this fictional story, and it was the most freeing experience for her. But it was such a challenge for me because I felt like I couldn't help. I felt like I just really didn't know what to do, and it taught me a lot about consulting and making sure that I'm staying connected to people out in the community that are doing the work and reaching out. So I'll always remember that.
I feel like that's a really hard question. I think one would be that, I think, balance that happens with, if you think about what a person's been through, how that's impacting their lives. People are at different stages with when they're ready to deal with what. And so one challenge that I think of is balancing their autonomy as to when they're ready to do something with clinically trying to take those small steps forward and balancing that and being in that dance, if you will. And that can take some being creative. It can take just working in a different kind of pace. And sometimes manualized treatments are great, but they don't always fit the bill because everyone doesn't have the same criteria that goes through that. And so that's one challenge that I think of. Another one is just balancing, I think, self-care as well. There's a lot of different pieces that come up. I know for myself that I've learned to take care of myself in different ways to make sure that I'm staying on top of that so that I can be at 100%. I remember in grad school, we got this talk, first session in we were working on my doctorate. One of you will be the first person to get a suicidal client, and everyone's like kind of looking at each other like, who's it going to be? And it got to be me. And I got out of the session, I got my supervisor involved, did everything we needed to do. I needed to go to the grocery store, and I realized when I got home from the grocery store that I had bought too many groceries to actually fit in my refrigerator. Just like I had been throwing things in, and at that moment, my supervisor called and said, "Are you taking care of yourself? What are you doing?" And I was just, oh wow, I didn't even connect that. And so that was a real eye-opener for me as far as how important it is to stay on top of self-care and monitoring how we're feeling so that we're being where the client needs us to be versus where we are and in our own stuff. So.
Thank you guys so much for sharing. We'll go ahead and transition into looking at our case study. So if you look in your packets on the second page, you'll see the case study that we're going to be working from. So if y'all want to take a few minutes, we'll give you 2 to 3 minutes to read over it just to familiarize yourself, and then we'll kind of dive into the conversation. Some of the main points I have up here on the slide. So the client is Claudia. She is a 20-year-old Latina student and a single mother. So her index trauma was a car wreck, and her diagnosis is acute stress disorder. And so we have some treatment plans. You'll see the next couple of pages are treatment plans that have been put together by our panel here. And so how this is going to go is we'll kind of go one by one through the treatment plans, and I'll have you kind of go over your approach, and then we'll have some discussion as well. So as someone is sharing, if someone else wants to jump in, we can make this conversational as well, but we'll kind of go through each one first. So we'll start with you, Dr. Green.
So if you think of this young woman coming into primary care, the first thing is, okay, so they're thinking about, does she have any residual injuries from the accident? But ideally, thinking of trauma-informed care's approach, when she walks in, the whole atmosphere should be both physically and emotionally safe. When you go to an airport and there are all those long rows of seats, do you see people sitting next to each other if they don't know each other? Of course not. Same thing in healthcare providers' offices. They're encouraged now to do much more physical space between chairs to allow people that physical safety. We want the environment to be clean, non-cluttered, soothing. And then as you find out that this was a car wreck, even acknowledging that it's not unusual to have some of the symptoms that she's experiencing, and that they may last for a while, because what you're really doing is leading into, you're going to be referring them pretty quickly, more than likely. Sleep is an issue, and some primary care providers are going to be quick to want to prescribe something. I'm less likely personally to want to see that happen until some other sleep hygiene, non-pharm methods are tried, because it's not unusual after a situation like this to have sleep disruption, and to help her understand that that connects to some of her concentration difficulties in school, that connects to some of her irritabilities, those kinds of things. So if we can help her get her sleep right, that will impact some of her other difficulties. So with trauma-informed care, you're doing a lot of explanation and anticipatory guidance for her, not necessarily providing any of the actual mental health treatments, but just helping her by getting that ready, and allowing choices as much as possible. Like, she may know of somebody who she's seen before, that sort of thing, or has a friend, because you want to set the stage so that she'll be able to make choices as much as possible, and to acknowledge that this is something that you can recover from, and that's why you're going to be referring her. And then I think about the school situation as well, and help her understand that, I want to know, where is she doing her clinicals right now? If she's in the emergency department, if she's in ICU, she's seeing people who have come from trauma injuries, that may not be the best thing. She may need to talk to her faculty. She also, with other things here, and you'll get to that, I'm sure, with some of the other things about financial aid and those kinds of things. So that's pretty much where I would be at that point, is working on helping her accept referral, and with a special focus on some ideas to help her sleep, that's something that I would want to follow up with in a short time to see if that's gotten better.
And you mentioned referrals. What
Yeah.
would that look like from your perspective?
It's one of those practical things. It would have to do somewhat with her benefits. And it's like, if she's a Del Mar student, I might refer to the Del Mar Counseling Center as one option. I might refer to Behavioral Health in Oasis County. If she has good insurance, we might look at her provider list for that. But I don't want to just give her one option. I'd like to give her a couple of different options. Ideally, in the clinic that I'm working in, we would have already had a relationship established with several people in the community who are providing behavioral health, so that I'm aware, so I could make my best guess at a good matchup for her. And also let her know, and if it doesn't go well, we can always brainstorm again, but just really trying to set it up for a positive experience for her, and to let her know that at some point her family might be brought in to help them better understand that those are, like the family being resistant, that's kind of a secondary issue. So I would want to have somebody in that office even help her call if possible and have an appointment established before she walked out the door. because it can be very challenging to have to go home and do that when she's already feeling pretty challenged and overwhelmed.
So looking at the course of treatment and your role in seeing some of those symptoms reduce, what would that look like kind of over the course of your interaction?
I would just want to know, and I would really want follow-up from, because it's, again, I'm mindful of her time and demands and her resources. I would just call on the person or people that she's referred to get back to me if she's not sleeping, if that continues, or if there are other kind of somatic things that develop, because sometimes over time more physical things emerge. So that I wouldn't necessarily think that she needed to come back, but I would want to stay in the loop to see how that played out.
That'd be something that you would stay connected to
Yeah.
the other providers.
And even, you know, it's like I know that their time is limited, so I don't expect every visit to have an update, but you know, I also don't want to rely on no news is good news. But if she didn't follow through with the appointment, I would want to know that. And if there are things I could do to help reinforce the work that they're doing, I'd want to know that. And again, looking at sleep in particular, and again, not wanting to jump to, I know that she has anxiety, I'm not wanting to jump to medications for that right away. I want to give treatment, I want to give treatment a try first, or especially something like the use of DBT skills or CBT skills.
Dr. Taylor, we'll jump to you next in your treatment plan, looking at it from the perspective of assessment. What would your goals be in working with?
I thought I put assessment on there. I'm looking at it. So I'm just going to talk about it. So the first step that I would take would be to try to clarify exactly what's going on. She has what appears to be an acute stress disorder, trying to make sure that we identify what's happening so that hopefully it doesn't progress to something like post-traumatic stress disorder. Since it's only been about 2 weeks out from her car accident, we also want to make sure that I wouldn't put pathology to something that's a normal response. After being through a significant car accident, everyone's going to have some dreams, some what we call intrusions, or maybe some feelings of avoidance of being uncomfortable being in a car. So I'm very mindful of trying not to jump to that, okay, you meet criteria for a mental disorder, because there's sometimes I think a tendency to do that, sometimes in the community of mental health. And some assessments that I would use to do that, and on your slides, I have clinician administered PTSD scale for DSM-5, and I wrote PCL-5, and PCL-5 is not the CAPS. So I'm sorry. The clinician administered PTSD scale is the CAPS. And so while she doesn't meet criteria for PTSD, I would still give her that scale, because what it breaks down really clearly are what symptoms are related to what we call the identified stressor. In this case, that would be the car accident likely. And so understanding, is it about nightmares? Is it about avoidance? Is it about this is my fault because I talked to my friend and my friend was talking to me when the car accident happened. So getting some clarification on what's happening there to inform the therapy that we used. And also something called the Life Events Checklist, which is an assessment that I really like. It's not complicated. It's literally a list of events that people might have experienced. And where that would be significant to me is that I don't know, for example, that this is her first car accident. I don't know that she might have been through some other significant stressful events. And, is the car accident the big deal, or is it something from her past that the car accident reminded her of? That's a big deal. And so getting that kind of history would be able to help me inform the assessment and what things are coming up. Because if you have a previous traumatic experience and something else happens, people can go to that place of, I knew it, or I was right to think that way, I should have kept that way of thinking, I shouldn't have let my guard down. And so that allows us to better make sure that we're addressing the thought processes that are going into some of the difficulties that she's facing, working with her to identify some treatment goals, and then working with the primary care side, like you mentioned, if there's medications, if there's no medications, Is she open to taking small steps? Some people refuse to take medications at all. And so therapy can be about doing some self-care, sleep hygiene, small steps to get them to that place that they have some solid coping skills if they do go through some difficult individual or group therapy sessions. And I think that's a pretty good way where I would start.
And I would ask you, it's like when we talk about sleep hygiene, probably having her actually practice in your office some progressive muscle relaxation,
Absolutely.
some of those things, not just tell her about it, but actually practice so you know that she knows what you're talking about.
Yeah, practicing it in the office, and then typically if someone's going that route before I do any kind of therapy, our therapy that's focused therapy for the trauma, my first couple sessions is checking in to make sure they're doing that stuff regularly. Because, it might sound great, yeah, I'm going to do that. You get home and there's not that person going, did you do that? And so making sure that that's her practice before we get started would also be a strategy thing. It's a good point.
So why don't you share your perspective from the case management side of things?
So when I read this is, I've seen a lot of students come though to me, or get referred to me rather, in this specific situation where there was a car accident, there was something that happened on their way to campus. They rush up to their professor and say, oh my gosh, this is what happened, this is why I missed class. And the professor says, I think you need to go talk to somebody over in eye care. And so this sounds very similar to a lot of students I've worked with even just this semester. So what I would do when working with Claudia is to first assess needs. My overall goal would be to connect Claudia to these ladies here if needed, but I gotta kind of figure out where she needs to go first. So I would have her complete a needs assessment, which is based on Maslow's hierarchy of needs, to determine what needs are not being met. So it's going to be really difficult for this student to get counseling with Claudia or talk to a doctor about medication if she doesn't have any food at home, if she doesn't have medical coverage, if she doesn't have child care, if she is having difficulty with her 3-year-old. These are all things to be mindful of when you're working with someone like Claudia. I'm a mother of a 3-year-old, and so I know that it's a challenge to get anything done at home, especially homework that your counselor or your psychologist assigns. Having a 3-year-old running around can be very distracting. So kind of keeping that in mind. But first and foremost, I would assess Claudia's needs and determine what resources and supports would benefit her. And then from there, we would develop a plan of action, a treatment plan, whatever you want to call it. I call it an eye care student success plan. And so we would take these needs that aren't being met and develop goals collaboratively to get this student connected to as much support as possible. So that may include counseling, that may include a referral to a psychiatrist or a nurse practitioner. My goals here on the treatment plan, and I've mentioned this before, self-care, self-advocacy, making sure that we're involving the student support system. She has a 3-year-old, so who's going to be watching the child when she's at her therapy appointments or when she's seeing her psychologist or her psychiatrist. So making sure that that support system is there, whether it be family or friends, informal supports, or more formal supports like a daycare or what have you. So making sure that she has that support system in place, because that's going to make all the difference in terms of continuity of care and her continuing treatment and being able to follow through on these things that the treatment providers are recommending. So assessment, success planning, following up, making sure that the student is connected, and throughout this process, really educating the student or the client on medication, the process of counseling process, diagnosis education if there is a diagnosis, And also something that's really important that I work with my students on is that mind-body-spirit connection. And so when you're working with people, clients or students, families who have experienced trauma, a lot of times that mind-body connection is lacking. So encouraging things like guided progressive muscle relaxation, or yoga, or even things just as simple as exercise or going for a walk. And that kind of falls under the self-care side of things too. So self-care, self-advocacy, and that support system, and making sure that that student is connected to as much support as possible. Being on campus, it's not that difficult for me. We have a counseling center, we have a psychiatrist, we have a health center. So I
teach in counseling.
Yes.
Free.
Exactly. So it's not that hard for me to get my students connected on campus. When I have a student that I need to get connected off campus, it's a little more challenging. But for a college student like Claudia, we would get to work, assess needs, get a plan in place, and follow up and follow through to make sure that she gets back on track with her studies.
I have a question, and it's because you are a mom of a 3-year-old, and you know, I was always kind of preoccupied in this case study about the 3-year-old because I know how quiet they are.
They don't make a purr.
Yeah, and it's like, and she's sensitive to loud noises with the speaker system and stuff, and I have a 3-year-old grandson who, you know, likes the whole pots and pans thing and that, you know, so those loud noises. So I'm thinking that she's going to need some practical tips right away that she can take home, like today.
Exactly. Self-care piece.
Yeah.
Her being a mother, her being a student, and as Dr. Green mentioned, those 3-year-olds, their job is to make noise and messes and yell and scream and cry. So yes, having those skills at home, like the progressive muscle relaxation or yoga poses she can do at home, and kind of working with her 3-year-old and making that a game, and doing those things with the 3-year-old to have some quiet time.
I'm curious, Stephanie, what would your interaction be with a client kind of throughout the course of treatment? Would you be meeting with the client regularly? What would that?
So we would meet regularly to review the success plan or treatment plan or whatever it is that you call it, just to make sure that they're following through with their providers. Getting consent is really, really important so that you can follow up with all of the providers, making sure that that consent is in place. Making sure that you're always asking for permission, and making sure that it's the client or the student that's making the decision in terms of their own treatment, but following up with them regularly. Sometimes I meet with my students once a week, sometimes it's once a month, sometimes it's just, you know, twice, 3 times a semester, just to kind of check in, but reviewing their success plan. And that also is an opportunity to catch any barriers or challenges that come up, so we can deal with it and not have that be a reason for them to not continue their treatment.
I'm just curious because of working here on campus, and I think that the eye care team does a tremendous amount. At any given time, I'm curious to find out what is your kind of caseload? How many students do you typically follow?
This semester, it has been 185 students referred to me. It's just me. When I say eye care, I mean me. I'm the case manager. I have a supervisor who's our associate dean of students who oversees eye care and student conduct and community standards. But it's just me that's doing kind of the day-to-day stuff. So this semester, 185 students were referred to me. Of those 185, 13 of them were required to do a mandated safety assessment through the counseling center because they had significant suicidal ideation and or a suicide attempt. And this semester, the majority of those 13 mandated safety assessments were suicide attempts. So it's been quite a busy semester with a lot of more severe mental health related challenges that 9 times out of 10 include some form of trauma.
And Claudia, can you tell us a little bit about your work with Claudia? Hi, Claudia.
So for me, if Claudia came into my office, one of the things that I would probably do, her being 20, I would not be looking at trauma-focused CBT, but I would be wondering if she would be interested in using cognitive processing therapy. Now, I will tell you it's not for everyone because, I mean, you guys are going to talk about it today. It's very manualized. And as was mentioned earlier, it does not always fit for everyone because there's a lot of homework involved. I mean, it's step by step. Now, can you kind of waver and add some things in? Yes, but you need to really kind of stick to that. And so I would want to try to gain some consensus in regards to whether or not Claudia feels like this would be a good fit for her. And so that's, you know, Dr. Lentz had mentioned using CPT in this particular treatment plan. And so for me, that's kind of the approach that I would take with this case. And I would want to address the index trauma, of course. Some of the other things that I put on the treatment plan outside of the goal of helping her be able to work with minimal anxiety or fear-provoking symptoms, because again, I don't know if she truly has anxiety. I agree when you mentioned how these are normal symptoms. These are things that do occur whenever someone goes through a situation like this. And some of those things can pass with time with no treatment, and sometimes it can't. But I listed also underneath the goals, and I believe that it'll occur through the actual treatment, is the focusing and concentrating. I think that'll come through working through that trauma, as well as feeling less irritable and working on those sleep patterns. I think that can also come as Claudia works on some of those things. So some of the interventions that would be used follow the CPT treatment, which is working on stuck points. So identifying those areas, you know, sometimes we will say things like, I should have known that car was coming, or I should have known not to ride. The shoulds, the oughts, the woulds. We get into those strong beliefs, and we need to be able to work through restructuring those through cognitive processing of that information and that maladaptive thinking that you guys talk about in class. And so you want to look for the problematic thinking and help them kind of work through that. You would see Claudia every week, so I would have her coming in each week, and I would be asking her to do those assignments and doing an ABC worksheet. If she is struggling to do those things, because it's going to happen. I'm going to tell you right now, we're busy. She's got a 3-year-old, she's got school, she's got all this stuff going on. I would not want to do the worksheets. And be like, lady, I don't know what you're asking me to do, I've got enough. So what's encouraged in CPT is if that's the case, you start off your first session, or you give them time in the lobby to actually complete those assignments. And they're really important because I'm working to have her develop those skills independently of me. She is going to work through that. She needs to be able to work on self-guided cognitive restructuring to help her also decrease her trauma symptoms. So we work on them in session, so there's some modeling, there's some role playing, we want to practice those things, but then also outside of the session. I also agree that you cannot work on the trauma event without knowing that she's got some tools that she can go to in regards to her being re-triggered, those intrusive thoughts, the hyperarousal, that type of stuff. She's got to have some go-to skills, something that she can pull from when those moments come up, or you're going to re-traumatize her. And I put that in some of my other slides, I don't know where we are on it, that you want to really avoid that as much as possible. So you've got to know where your client is at. So I'm going to work with her and make sure she's using those skills, she's practicing them, she's sharing with you these moments that come up in her day-to-day work, and when she's out there in a car and somebody else is driving, and she's able to use these skills that we're practicing so that we know that she is ready to work on that trauma event that has happened. Now, one of the things that I'm real careful with Claudia is maybe she didn't want to talk about all the events surrounding what happened that day. She doesn't have to. But you do want her to be able to talk about the things that led up to it and to work through that. So sometimes I think we can get caught up in wanting to make them talk about all those little details. But with Claudia, I wouldn't do that if that's not necessary. CPT supports that. And so I would really want to work with her where she's at, kind of go with her on that journey. CPT, it doesn't take a whole lot of sessions. I'm not going to have her working with me for a whole year. It really focuses on the least amount. Research shows that it's long-lasting as well, so we're looking at 12 to 16 sessions, but that's something that I'll figure out with Claudia at the beginning.
So the four of you, if we could kind of imagine that you're kind of her team of providers, she sees each one of you. What would that look like for the four of you to work together? What would be some of the things that you would be able to collaborate on and work together on? What would be some of the things that you want to communicate about? To kind of tell us what that would look like for the four of you.
Well, it'd be my job to get Claudia connected to these ladies on up here. So it would kind of depend on the insurance sheet. She may have veteran benefits. If she does, then getting her connected to the VA side of things. If she does have private insurance, getting her connected to someone like Claudia. If she's needing to be evaluated for medication, or say she has some health concerns, getting her connected to the medical health side of things with Dr. Green. She may even be a student of Dr. Green, depending on if she's in the nursing program or not. Making sure that I get consent from Claudia to be able to communicate with all of her treatment providers, and educating her on the function of each one of her treatment providers and what the focus is going to be with that treatment provider. So she's aware going in and what she's going to be working on with that particular person.
And one of the responses I would have from now, wearing a faculty hat, not a provider hat, is, you know, to coach her to really communicate with the faculty that she has at her school at Del Mar. Because again, I am concerned about her being a bit distracted and not being able to give full attention in a clinical setting where we take our nursing students. Nobody wants to risk her not doing her best. And so it may be a time when an incomplete is quite appropriate. And typically faculty will work well with students on that because they have no desire to have an untoward outcome with the patient care that a student is providing. And again, it may be appropriate for her to at least consider an incomplete for even the didactic part, or if she's not doing the clinical, she may do well with the didactic part because that lessens her weekday. It gives her essentially 6 or 8 hours back, that sort of thing. And you know, and you probably have evaluated her. Does she even understand all the financial aid that's available to her? Because often we find our students, they may get some, but they're not getting as much as they can. And for our nursing students, there are always new grants that are opening up, both individually and for us programmatically. We have a lot of grants, and I'm sure Del Mar probably is pretty similar in that regard.
From the academic side of things, it's going to depend on where we're at in the semester. Yeah. If it's the beginning, the middle, or the end, that's going to play a big role, teaching her and coaching her how to communicate with her professors. I often reach out to professors on my end, just letting them know, students connected to iCare, please let us know if you need anything type of email. Yeah, I think that's really important to make sure that we are advocating and teaching them how to talk with their faculty members. Another appropriate referral for Claudia might be our disability services office here on campus, and getting some accommodations for in-class. And those accommodations are going to be based on her treatment provider recommendations. So making sure you have consent to talk to treatment providers, to communicate that back to disability services, just getting all the accommodations in class that she needs.
The consent piece is very important for each end, you know. So if I'm working with somebody, if I need to have a conversation with their case manager, having those consents up front, and then just making sure I'm having contact with the primary care side. So if she does eventually get on medications, if there were any physical injuries related to the car accident that are causing, you know, ongoing pain issues or things that she needs to address, making sure that we're integrating that if possible. I mentioned the assessment piece. There's also the question on if I would transfer her to a different provider or if I would keep her to provide the care myself. And so, you know, if I'm transferring her to someone else, to make sure that, you know, if we do need to do a future assessment or check in on anything later, that I have, I can sit with that provider in a relationship with them, or if I'm providing the care, making sure that we're keeping up with the primary care piece as well as the school side, if that's something that needs to be brought in to try to keep improving.
You know, I also want to highlight that because sometimes I think we are not aware of who the client is working with. And so we do want to know from Claudia when we're first sitting down with her, who's all on her team. Because for me, if she's seeing a psychologist who's actually providing the therapy as well, then I don't need to do that because you don't want to have, you don't want to double dip, especially in managed care. That's a big no-no. So you definitely want to be aware of that. Those are conversations you should have in your first session when you're doing your intake and you're asking those questions, because people do want to wrap services around people when they go through situations like that, when there's mental health needs present, and I think that is wonderful, but sometimes we can overlap and end up duplicating. So.
I think in some settings you have providers from different disciplines housed in one setting, but a lot of times, and I think probably at a lot of places here in the community, those different providers aren't under one roof. And so I think what you were talking about, Dr. Taylor, of really knowing who your clients are working with, but then also you as the provider having connections with other providers in the community to know who to partner with or to be able to follow up with some of those things like that. And I think that really falls on us as individual providers to create those networks and connections to be able to have that.
But I think, Stephanie, you said something earlier that's real important. We're talking about food even, and a lot of times our students have been embarrassed to say, you know, our cupboards are bare. And I know she's got family involvement, but they may or may not know the extent. And so it may not come out right away, but any one of us could hear that, and knowing that you're involved matters because you have the keys, so to speak, to Izzy's pantry, for instance, you know, and not everybody knows that we have a food pantry for food insecurities for our students on campus, and those kinds of services. I mean, you become kind of a real pivotal and important person here.
You know, I think that even happens in the community, and Stephanie can probably speak to that too, just as, you know, providers in general, you get people who come in and you want to know what's out there in your community, because you can swear up and down once you get out in the field that you're only going to do clinical work, but part of clinical work is going to be case management. So you want to get comfortable with that, like really comfortable with that.
Like I mentioned, like it's going to be really hard for your client or your student to do some good work in session with you, good therapy work, if they're hungry, if their electricity is about to be turned off.
Or was turned off.
Or was turned off.
Yes.
If they're not able to pay their rent and they're on the verge of homelessness. You can't really get much done in session when this client or student is worried about all these other things.
I think that should just the times when it is important to bring in other people to be a part of that treatment, and why these different perspectives bring so much richness to that treatment process.
You know, if I could highlight one thing, I had this one family, they drive in from Kingsville to see me, and I have another family who drives in from Robstown, and they have me sign this little form every time. And one day I asked them, like, why do you, it was like a work excuse form, but she doesn't work. And so I didn't know why she needed it, and she said, well, Medicaid reimburses my travel. Bam, thank you. So then I get this family coming all the way from Kingsville, and I'm looking at them, and it's a big family, and he was saying how, you know, well, it's hard, and I might miss because I have to work, and I don't have a lot of money, and, you know, I was just kind of assessing things, and it just clicked to me with my other family, and so I linked them to that and helped them understand, like, you can get reimbursed. Kingsville to here, like, that's a lot. So the fact that they'll even reimburse that, so put that in your toolkit if you're working with families who have to travel a bit of a distance to see you. Just know that there is some reimbursement for that as well.
And keeping in mind that resources and supports are always changing. They're always being taken away, they're always being added. after Hurricane Harvey, there was all this money coming in, we didn't know what to do with it, and we distributed it to students and got them as much support as possible. So, like Claudia mentioned, being aware of these things that are going on in the community are going to help you with, I promise you, they will help you with a student or a client in the future. But know that things are always changing. So what was there this time last year may not be there. And so it's going to be important for you on your end, in that case management piece of things, to do that research and make sure that you're aware of what resources and supports are available, not just within your agency, but within the community as well.
I'm wondering, kind of in closing, if we could spend a few minutes maybe talking about any additional considerations that you noticed in a case or that you would want to keep in mind in working with Claudia.
I think some of them have already come up. We talked about the child care, where she is in school. One that I was thinking of in addition to that was the family environment. We know that there's family involvement, but we don't know that family dynamic. For example, are they okay with providing the support that they're providing, or is there some friction related to that?
Well, we do know there's a little friction because they'd like her not to be pursuing a degree in nursing.
Yes.
And then at that first part, there's like they're providing a lot of the support.
Yeah.
So what does that
So
look
they
like
may
on a
be
daily
eager
basis?
for her to get out and just get a job.
Right.
And
The
drop
text
out of
is right. They
school.
want her to do that. Get up and get out. And so exploring more of that. Another one that came up for me was substance use. Like, does she drink or use other substances? Is she on any prescription medications or medications that are prescriptions but not prescribed to her that she could be taking that we don't know about?
Her mother has it in the medication kit.
Yeah, exactly. Like just getting that information as well. And then kind of what that might look like for her presenting as a Latina female, if there's any concerns related to that, or even being female, and whether or not that's something that's playing a part or some things that came up for me.
I think just being Latina myself, I'm Mexican American. I don't know necessarily specifically the origin of Claudia, but is English her first language? Is it her second language? What language does her family primarily speak? When you're involving them in support, that's going to be helpful information if you're wanting to involve family, but they don't speak very much English. So kind of keeping language in mind.
So I had some thoughts about like whether or not they believe in treatment and therapy in general, or do they believe strongly in their belief systems? So I don't know what that is. I don't know if they're religious, if Catholicism is what they practice, or if they're Christian or Muslim. I mean, you just don't know. And so it's kind of like wanting to explore that and kind of see how that might tie in to maybe how she works through her recovery, being willing to incorporate that.
And letting her know that she can do that, because I love that you mentioned that religion piece, because some people don't think they can. I've had people tell me, well, can I talk about that because you're not a Christian counselor? And I'm like, well, psychologists, we can incorporate what you want to incorporate. It doesn't mean I have to have a certain heading. So letting people know that they can be empowered to speak for themselves and let us know what they want to be part of treatment is also important.
Because it always, no matter what, gets back to if we are truly person-centered and really focus on not what we all think, but on her choices, on her values, you know, that will help bring in cultural considerations for her.
I wanted to take the last 5 or 10 minutes that we have for this portion to take any questions from the audience. So if there's anything that you would like to ask of our panel, raise your hand and we'll field some of those questions. Yes.
Dr. Traylor, this is for you. You mentioned the life events checklist. Would you give that to your client prior to doing the PTSD scale?
Yes. Usually I will administer the life events checklist first. That's like I said, short form of different experiences, and on the back it asks the person to identify the worst experience or the thing that's coming up the most. When we're doing the clinician administered PTSD scale, we look for the stressor that's causing the biggest issue or the identified stressor for criterion A. And the life events checklist helps inform that, so you can know, you know, they lived through a tornado and no one was hurt, or they've been assaulted, but this thing is coming up the most, to be able to incorporate that.
So it gives
yes.
you the hint to start with of
Yes.
where it, gotcha.
So I know in the beginning you guys had kind of touched on referrals and referring clients based on insurances. So those of you that work with insurance companies, how do they react with manualized therapy? You know, like some of the tougher ones like Blue Cross Blue Shield, United, are they for manualized therapy? Are there reservations? What does that look like?
Well, if it's based on CBT, they're gonna love it. That's what they want. I mean, that's, in the world we have today, I mean, managed care wants you to use an evidence-based practice. You're gonna hear that word all the time. But again, I go back to, like, it doesn't always work. Like, we really have to think about what's gonna speak to this particular client and help this client. Now, do I need to throw some CBT in there? Because I got a bill and I need to get paid or what have you? Yes, I've got to make sure that I'm doing that. But just to use anything, no. So managed care loves evidence-based practices. If you just ask them, they will tell you. And sometimes they're going to send you a form, too, that you have to fill out that tells them what you're doing. And how many, you have to request sessions, how many, you know, you are asking for, and what the goals of treatment are going to be. And I mean, it gets...
So that still doesn't mean you can't be a tiny bit eclectic.
Say it again.
That still doesn't mean you can't be a tiny bit eclectic.
Exactly, exactly.
Okay.
They're not sitting in the room with you. It's recorded.
Creativity. Be creative. Always be creative. They get very, very detailed.
Any other questions?
So one of my questions is about the sleep hygiene. She hasn't slept for 2 weeks very well. So what are some things that you all would try before recommending prescribed medication for sleep?
Some of the initial things are almost common sense, but today, you know, we are so plugged into our electronic devices. It would be no TV, no screen time, not even phone time, for about an hour or so, or even longer before bedtime, because that really does impact the brain.
Yeah.
And you don't have to necessarily give all of the details of that, but limit the screen time, start winding down, have it a bedroom that's ideally cool, dark, and a pleasant thing. Routines, not rigid schedules, like it's tough for students, because especially a mother of a 3-year-old is probably staying up late and finishing papers and getting up early, but trying to find like at least a 6-hour block that's a regular block, ideally longer, but that's a starting point. Doing things during the day that give her exercise, and you think, well, she's working 3 days at a daycare and she's got a 3-year-old, but that's not the same as carving out time for a 15 or 20-minute walk for herself. And then the obvious of cutting down caffeine before time, heavy meals, no chocolate. And sometimes people think, well, you know, a glass of wine or a beer before bed would be a good thing. Actually, that's a sleep disruptor. It may make you drowsy initially, but then later you'll awaken and have a harder time getting back to sleep. So those are some of those just basics, and y'all may add to that further to start with, and have her do that really for several nights in a row.
The self-care piece is really important. Being, like I mentioned, being a mom myself, us as moms, and Claudia, you know this, we always have checklists. So we go to bed with going through those checklists of what we need to do the following day. And so teaching Claudia how to kind of plan for the following day and being consistent with that plan, so that it's not keeping her up at night when she's thinking about all these things she has to do at work and school and with the 3-year-old.
What about over-the-counter, like things that the NyQuil sleep? Would you recommend something like that or not?
I would be reluctant to recommend that at first. I would really try to encourage her, because it is about helping her reclaim her power and stuff, and acknowledging this is not unusual to have these kind of sleep issues. And there are going to be other times in her life that she has them too. I would like her to build her skill base, and so that's why, you know, kind of make this sleep hygiene routine and have her really try that. But monitor it closely, because you don't want her to go without sleep for a long time. We know her sleep is interrupted. We don't actually have enough information yet either as far as, so how much sleep is she getting? We would need more information. So it may be, in fact, that she'd need medication. And I would really rather manage it and not have it be PRN and not have it be over the counter. We want to know what she's using because it's just too easy to go down slippery slopes when you start dabbling.
And most people think over-the-counter meds are safe, but things like melatonin or Benadryl or whatever it is that you're taking to help you fall asleep at night. But I've had a lot of students tell me that they have negative side effects from those medications, and it does the opposite. It doesn't really help. So being very careful with that is important.
For me, when I took the master's program, I took that stress management course, and I actually was not a firm believer of like that kind of stuff. It worked for me. I really struggled with migraines and insomnia, and it was one of those things that happened after pregnancy. I had no idea, and nothing helped me, and I'm not big on medication. So I took that course with Dr. Bieberstein. After the 3rd week, I was sleeping in class. I was so embarrassed because I would fall asleep, but that's the whole goal, right? So using that, if you took that course and it worked for you and you really learned how to truly deep breathe, teach your clients that, because that's what's going to help them honestly be able to work through some of that, to be able to keep those routines, and when it's time to lay down, that they have that process.
And that's something they can do anywhere. The child can be running around in circles.
Teach the child. Teach the 3-year-old. Y'all lay down together and you do it. Our phones now, there's so many little things that you can, apps and stuff that you can put on there, and it's soft music or it's the water or whatever. So that's what I would do.
All right, one more question.
As far as like treating trauma goes, from what I've read and everything, it sounds like there's like these two ideas of, some people think it's necessary to go back and discuss the traumatic event, and then there's another idea of like you don't have to focus on that at all. So I was wondering what your opinions were on that.
Well, I guess it depends on the client for me. I've worked with some that it's not something that they're willing to do, but they're still able to work on the trauma without talking about the actual event. So I've seen the research on both as well. And for me, I have to base it on the client.
And I would just reiterate that in suicide work, which is often a link, there is a link with trauma, the place we typically start is providing some very tangible skills for coping initially. And it's very interesting, after about 4 or 5 sessions, often the person's feeling well enough, they don't want to do anything else they want, and so it's individualized, and so we don't have to go back and go through whatever, because they've got the skills and they aren't interested. But we always leave the door open to say, if you start finding yourself sliding down that hill again, we might want to try something further, and that usually works out. And this is through David Rudd's work, which is campus-based, and he finds very few come back, and in tracking them, they don't go on to kill themselves. They stay alive and thrive.
All right, well, thank you guys so much.
Really appreciate it.